Greetings, fellow registrars. My name is Kelly Olson, and I'm here to present on texting, not just for teenagers. I am a cancer registry director here in Southern California, so I've seen a lot of different text documentation, and I also started my career, interestingly enough, with a central registry. So I've seen it from both the quality review aspect and from a training aspect. So hopefully you will be able to get something great out of this presentation. Many may think that text documentation is easy or a basic subject, but even the most experienced registrars sometimes could use a little refresher. My objectives today are to explain why text documentation is important, discuss the elements of quality text documentation, analyze specific examples of appropriate text, and review the expectations on text documentation from a quality reviewer's perspective. So why should we care about the text? Well, an abstract summarizes in a detailed and succinct way the story of each patient's cancer diagnosis and treatment. The codes are a way to universally compare the data, but text is essential for that backup of those codes. You can't tell a story with only codes. You have to get a true picture of the patient's journey, so you need those details that are found only in the text documentation. So let's take a look first at these three statements. I took my son to Galaxy's Edge in Disneyland. These are all codes. It was snowing in Denver in May. I ran the San Francisco Half Marathon in 2 hours in July of 2018. So let's consider these statements, as I mentioned, to be the codes that I've put into my abstract. But how do you know that these statements are true and accurate? So these pictures are what we would call my text. This is my backup, just like the text in an abstract. They support my statements. And as you can tell, these are all pre-COVID examples, when everything was still open. And those of you that attended the NCRA annual meeting in 2018 realize that this was true before I even provided you the proof. But you can see from the pictures, there I am with my youngest son at Disneyland at Galaxy's Edge. You can see in the middle picture that it is indeed snowing in Denver, and I have other registrars who will also back me up on that. And then you'll see my certificate of completion for running the second half marathon in San Francisco. But you might notice there's something a little bit off about that particular picture. So is there proper backup? The text in the abstract, like I said, is the proof for all of the coding, just like the photographs were the proof for my statements. But if you recall from the previous slide, the San Francisco half, the code that I put in was that I ran it in 2 hours. But the proof was not the same. It said I ran it in a little over 2.5 hours. So not only would I get a discrepancy for that statement, you also know now that I am not a very fast runner. But as you can see, it doesn't back up my code. So this seems like simple examples, but texting is truly the backbone of an abstract. So let's think about our patients for a minute. If we code multi-agent chemotherapy and didn't have any text or only wrote something like Taxotere, that isn't very helpful to the researchers. The text is not only backup of our codes, but it can also help the researchers when our coding system doesn't quite have the granularity that they need. We can't code specific regimens for chemotherapy. We can't code specific drugs for immunotherapy. Therefore, they need something more to know what truly happened. We don't code number of cycles. So you can see how important that the text is, not only to just back up the codes, but to give that really true, well-rounded picture. Which brings us to the importance of quality documentation. So quality text, it can do many things, but it uses appropriate abbreviations, it addresses all the coded data elements, and it is easy to read and comprehend. So with acceptable abbreviations, something to remember is an abstract is just that. An abstract is a summary of the contents of a book or an article or a formal speech, and in our case, it's a summary of the patient's journey through their cancer diagnosis and treatment. It's not the entire book itself. We cannot possibly include the entire medical record into our abstract. So our text needs to be short and concise. The best way to take advantage of our truncated text boxes is to use the abbreviations. Now, I'm from California, so the California Cancer Registry has been nice enough to provide us in their Volume 1 appendix a list of acceptable abbreviations. But if you're not as lucky as me to live in California, a quick Google search. So what you're asking yourself, well, okay, big deal. What does that do for me? Abbreviations are going to allow you to get the right point, and it will leave you enough room to be sure that you're getting all that necessary information in there. So let's look at these examples. The first example, chief complaint, 85-year-old African-American female with liver metastases present and on outside imaging presents for surgical consultation. Very wordy, 19 words. If you just use the acceptable abbreviations, chief complaint, CC, 85 YO for year old, AA for African American, female with the / liver mets, here for surge consult. You could even put surge cons, but still, it's 11 words instead of 19. The second example, very similar. When you spell it all out, you've got 13 words. CTs, you can, abdomen and pelvis, you do not need to write all that out. Multiple lymph nodes, consistent with METs, you can really shorten that up. And same thing for the third example, the right breast ultrasound. Look at how many, I only cut out 4 words, but just think about how much do you have to document, especially in imaging for things like breast. You've got so much imaging if they've had the mammogram, screening mammogram, diagnostic mammogram, ultrasound, MRI, bone scans. You need to make sure that you can fit all of that in. So the best way to do that is to make sure you're using the abbreviations. And I will just say from a trainer's perspective or a quality reviewer's perspective, I do not like a lot of wordy text. So this is really helpful to understand what's going on with the patient. So quality text also addresses all the coded elements. Again, I'm going to be California heavy here, of course, but you all should know STOR, NACER's coding rules, solid tumor rules, anything from SEER. Like I said, we have to follow our state rules. Of course, I don't even have AJCC on here. There's so many coded elements that we put into an abstract, but your text is going to back up every single code, even the simple codes like class of case or race. You need to make sure you document everything that you code. If you code it, you must text it, is the rule of thumb. So quality text is also very easy to understand. So take this poor confused mom on my example here. So mom is texting a daughter or son, I'm not sure. What does IDKLY and TTYL mean? Well, the son or daughter answers, I don't know. Is IDK, love you, talk to you later. Mom responds with, oh, okay, I will ask your sister, because she doesn't understand. She doesn't know that they're actually getting an answer to their questions. So this is clearly a communication breakdown. I mean, I'll admit I still have to look up some of these things when I'm on social media because I don't know what they mean. But in order to have good, concise research, compare apples to apples, everyone needs to be able to understand this in our field. So you have to make sure that you're using text that is easy to comprehend. And that's, again, why you need to use those acceptable abbreviations. So when I train new registrars, they really struggle with what text should they include. So besides backing up the codes, how do you know what to document? I always tell them that they need to think about what is pertinent to the patient's journey. This is one of my favorite words, pertinent. So what is pertinent? So per the dictionary, Merriam-Webster, pertinent is defined as having a clear, decisive relevance to the matter at hand. So pertinent information in an abstract, what's that going to be? How was the tumor diagnosed? How was it worked up and staged? What type of tumor is it, which includes histology, grade, stage, site-specific data items. And last but not least, how was the tumor treated? And then oftentimes what's not included here is any kind of recurrence information. So let's look at some examples of each of the main text fields and what might be included. So pertinent information for an HMP. So this should be when you talk about what happened to lead to the diagnosis and what is the patient's condition at the time of presentation. It's not always patient has symptoms. It's not always a simple, lab test, but you need to know why. You need to know how they got there in the first place. So examples, and I will use breast, prostate, and lung examples throughout here. Example 1 for a breast patient. So their chief complaint, 39-year-old female with a palpable mass in the right breast upper outer quadrant with biopsy positive for cancer, presents for surge. So the PE, 2 centimeter palpable mass at 10 o'clock, no palpable lymph nodes. So that tells us that this patient had a palpable mass, so this was not found on on the screening mammogram rather. They actually did present with a palpable mass. They've had a biopsy outside of our institution already that was positive for cancer, so they've been diagnosed. And you can palpate the mass on physical exam, but the lymph nodes, thankfully, are not palpable. So what about, and then prostate? So this is where you'd have a lab value, right? So a 55-year-old male with elevated PSA presents for biopsy. So they have not technically been diagnosed yet. All we've got is an elevated PSA. They're presenting to our institution for that biopsy. It's very important here, DRE within normal limits. Lung, 65-year-old female with a 50-year smoking history presents to the ER with hemoptysis. So symptomatic, decreased breath sounds, but otherwise within normal limits. So not only does this text documentation include all pertinent information, it's gonna justify some of the codes that you're going to use. Class of case, on the breast, you know that you didn't diagnose it, so it's at least gonna be somewhere in the 20 range. Prostate, your institution is likely diagnosing this. So it's going to be in the 10 range, possibly a 00 if they don't come back to you for surgery. Lung, this is probably going to be, again, either 00 or in the 10 range because they're presenting to you with symptoms. They haven't been diagnosed yet. And some of these items can also be used for clinical staging, the DRE within normal limits. Knowing whether a prostate is clinically apparent or not is going to be important. Clinical staging, you can use the 2 centimeter palpable mass for clinical tumor size for the breast. So again, these are not just, it's pertinent, it's how we got here, how did we get to the diagnosis, but it's also backing up the codes at the same time. So what about x-rays or imaging? So imaging is where I see a lot of new registrars struggle. They tend to list every single scan or imaging that they can find on the patient. But what we want to know are, again, what led to the diagnosis or the stage, which is important when it comes to imaging. So for our breast example, like I said, she had a palpable mass, so she didn't have a screening mammogram. She had diagnostic mammo. We need to include that. The ultrasound, we need to include that. Now you can see that the mass on ultrasound is 2.2 centimeters, which is going to up the clinical tumor size just a tad. No LID, a bone scan, no evidence of Mets. Prostate, the scans is going to be blank. You could technically put a TRUS if there are any findings on the ultrasound, in here if you wanted to, or if they did a bone scan for prostate. Lung, the CT of the chest when they presented. They did a CT of the brain, and they did a PET to do all of the staging components. So what you don't see is a chest x-ray for any of these examples. Why? Because it's not really pertinent. Usually, you only do a chest x-ray to clear someone for surgery. The only time it might even matter is on a lung case if the chest x-ray is where they saw something a little bit wonky and then they do further imaging. But that's not usually the case. But so you don't want to include that because that's just messing up your text fields and leaving you with little room for anything else. But what you'll notice is that the bone scan and the brain scan included for breast and lung are negative. So you might think, well, why include those? There's no findings. There is findings. The findings is that there's no evidence of distant disease. And you're going to need that information to back up your clinical M, or your staging in general. Neither of these patients have distant disease. How do you know that? Because the PET was negative for METs. The PET didn't show any METs, but the CT is negative for METs. The bone scan was negative. So even though a image might be negative, you have to think, okay, but is this done for the purpose of staging? Because if it is, you need to include it. Scopes is pretty straightforward, hopefully. What scopes were done that led, again, to diagnosis or stage? In my 3 examples, there are no scopes because none of them had them, obviously. Lung, you can't scope a breast, so that's kind of impossible. With lung, there's going to be scopes there. But this patient was diagnosed, in my example, by an image-guided biopsy, so no scope was done. So in this particular case, the scope would not be pertinent. But of course, if they had a bronchoscopy or mediastinoscopy, it's going to be pertinent and you need to include it. The sites where you're typically going to include scopes are colon, stomach, and perhaps any of the glottis. Labs. Labs is my favorite field because this is really what throws new registrars, myself included. When I first started abstracting, I would put any lab that patient had when they presented to our hospital, the CBC, anything. I would list it all, white blood cell counts, all those counts, anything I could get my hands on, because I had no idea what was actually pertinent to each of these cases. It's interesting because that we want to do more and more and more. But again, like I said in the beginning, this is an abstract, right? It's a summary. We don't need to include all of this extra information. Again, we keep rounding back to this pertinent idea. So for our 3 examples, breast, obvious, these have got to be drilled into your head, right? ER, PR, HER2, Ki-67. And now, of course, you do need as much documentation as possible for these to be able to do all red and things like that. So, in our example, it's ER positive, 100% strong intensity, PR positive, 70% strong intensity. HER2 new is equivocal, 2+ by IHC, negative by FISH with a ratio of 1.1. There's still some information that you probably can't code from the HER2 text, but it's, HER2 is very complicated. Ki-67, 10%. Prostate, PSA. One thing you want to note about the PSA is in the parentheses, it says elevated. Why include that? You would think, okay, 7 is clearly an elevated PSA. Not necessarily. You need to include positive, negative, elevated in those kinds of lab values because you don't know what range that lab is using. Not all labs are created equal. One lab might have 3 as positive, one lab might need 4 to call it positive. So you want to make sure that you actually list, is it positive or negative? So when trying to end lung, there wasn't any pertinent labs for this. So again, you might say, well, white blood count's kind of pertinent. It can be, but it did not lead to this patient's diagnosis. And it did not change any way that the patient was treated. So when trying to decide what labs to document, I always review the site-specific data items first. So then I know that I've got to cover all of my bases. If I code it, I must text it, right? So if there's a site-specific data item that's asking for specific lab values or intensity like all red, then I need to make sure that it's documented in the labs. And again, as far as pertinent, if it's going to change how a patient is treated, you need to include those labs, but almost always those are going to be part of your site-specific data items. So pathology, I would say, is the most straightforward. Almost everything is pertinent, right? This is when your abbreviations are really going to come in handy because there is so much information. It's text that should describe the primary site, the histology, the grade, and pathologic stage when applicable. So for the breast case, she had had a biopsy already outside, presented to our institution for surgery. So in the pathology field, right breast, 2.5 centimeter invasive ductal carcinoma in the upper outer quadrant, modified Bloom-Richardson 8/9, grade 3, 0 positive out of 2 sentinel lymph nodes, that's important, margins negative PT2 and 0 sentinel. All of that is pertinent information. What you might notice is I have left out LVI in the breast example, so you would have to code that to unknown. So like I said, you don't text it. It's kind of like what kids say, you know, doing it for the gram. If you don't post a picture to Instagram, did it even happen? Same thing here. If you don't text it, we can't prove that it happened. So since I didn't put LVI, I'm going to have to code that as unknown. So even in my examples, there are things that I forgot to include. With prostate, adeno-CA, Gleason 3 plus 4 equals 7, grade group 2. It's in bilateral lobes, 7% of the prostate, largest foci is 9 millimeters, 0 positive lymph nodes out of 17, no extraprostatic extension, or LVI, seminal vesicle involvement, all negative, margins negative, PT2 and 0. You need all of that information. This is going to justify histology of adenocarcinoma, your pathologic grade. You need Gleason for AJCC staging. Foci, we actually have one, which we don't get very often with prostate. It's going to do your pathologic tumor size, right? Lymph nodes positive over lymph nodes negative. There's no extension or seminal vesicle involvement. You need all of this for your staging. Margins negative, you'll need to document in surgery. And again, nice and neat PT2 and 0 for your pathologic staging. Lung, they had a wedge, right upper lobe lung wedge, moderately differentiated invasive adenocarcinoma, tumor size is 5 centimeters. Limit to the lung, no LVI or PNI, negative nodes, margins negative, PT2 and 0. I was very nice to these patients. I didn't want to give anyone really horrible disease. So as you notice, there's a lot of negatives. But you still, again, you got to include the negatives. Why? Because it's going to prove your stage. And why is it so important to prove stage? Because that's what your medical oncologists, your radiation oncologists are going to base their therapies off of, right? They're going to, if you have a high clinical stage, they're probably going to have neoadjuvant. If you have lymph nodes involved, probably going to have adjuvant therapies. So you have to make sure you include what's negative too. So treatment. Treatment should also be somewhat straightforward. There are some tricks to it, I suppose you could say. For operative findings, this is not a full-on description of what the surgery was, right? If they had a right modified radical mastectomy, that's not what you're going to put here. Operative findings are just that. What did they find during surgery? You'll say what kind of surgery they had in the surgery field. In the operative findings, you need to say what did they see. This is often, I tell my registrars to put procedure only or technique only or NA, because there isn't often a lot of observation at surgery unless they're having some kind of exploratory laparotomy. You don't see much. I mean, they could say, breast mass fungating in the upper outer quadrant. That you would put there. Lymph nodes matted and palpable. You would put that there. But if they don't describe any findings at the surgery, then you don't include that here. Chemotherapy. Again, names of drugs should be documented. This not only confirms the classification of the drug, because as we know, those like to flip-flop around. I don't know where rituximab is anymore. It keeps changing, or Herceptin. I think they're both immunos now. So it justifies that you've got it in the right category. And it's also, for chemotherapy, going to justify your code. Chemo NOS versus single agent versus multi-agent. You need to be able to, again, in my very first example, if I say you had multi-agent chemotherapy, but I only list one drug, how does that work out? You need to be able to make sure. And don't forget, you should reference CRX to make sure that your drugs are correct. Radiation is going to include everything on the treatment summary. Hopefully your physicians are giving you treatment summaries. I know that that's very hit or miss at my institution. Some of them are fantastic, some of them aren't. We don't get a lot of information on modality exactly. We have to make some educated guesses sometimes. But unless it's absolutely clear, don't assume. You know what it means to assume. So don't assume. You need to make sure you include everything, though, in that treatment summary. And again, this is where abbreviations are going to come in handy so that you have enough room to actually put all that text in there. Immunotherapy is just like chemo. You need the names of the drugs in order to confirm the classification. Transplants, you need to be specific about the type of transplant that the patient received. And where it came from, allo, auto, anything like that. And there are other treatment fields, of course. If you're using other therapies, you need to make sure that you document exactly what they had, which would justify it being other rather than it being in a chemo field or an immuno field. What I didn't include on here, of course, was surgery, because that is where operative findings and, again, surgery are different things, right? So surgery is where you're going to code, prostatectomy, lumpectomy, wedge resection, all of those, number of nodes removed, how were they removed, sentinel, lymph node dissections, margin status, and a surgery to distant sites. But your text is what's going to back up those codes. So that's where you're going to put right modified radical mastectomy, with 2 SLN and 12 ALNs. Your margins will be in your pathology, so that will back up your margins code. If you have surgery to any kind of distant site, you need to put that, and liver resection or liver wedge. That's where you're going to describe the exact surgery type. You're not putting it in operative. You're not putting it in pathology. This is where you document exactly the surgery that the patient had. So, helpful hints. There's a lot of information. So the first step, again, that I do to decide what's pertinent is I review the site-specific data items. There should be text backup to all of those codes in some way, shape, or form. Like I said, they might be found in different places. They're not all going to be in pathology, labs, some in pathology. Some might even be, in those clinical assessment fields. But you need to make sure everything is backed up. Some tests and data can be documented in multiple areas. So pick one and be consistent. So for example, Oncotype DX. Technically, you could put it in the lab section. You could put it in pathology because it is run off the tissue. You could put it in chemotherapy because that's what usually has the medical oncologist decide whether to treat the patient or not. I personally always put it in chemotherapy. That's what makes sense to me. I put Oncotype DX, the score, and then if they had chemotherapy, I list the chemotherapy. Or I put, Oncotype DX equals, what have you, low recurrence score, chemo not recommended. But the point is, always put it in the same place. I shouldn't put it in chemotherapy on one abstract, and then the next breast abstract I put it in labs, and the next breast abstract I put it in pathology. Be consistent. And don't repeat yourself, right? That's why I stressed you don't need to put the type of surgery in pathology and in operative findings, because you're going to put it in the surgery section. You're going to put it in the text box that is telling you exactly what kind of surgery the patient had. You don't need it in the other two places. We don't want to be redundant. We don't want to repeat ourselves. You should always document ERPR in labs. That's from a central registry perspective. That's just what makes the most sense to quality reviewers. Don't put it in pathology also. We already have to code it 1,000,000 times. You don't need to text it 1,000,000 times. Once is enough. And also include the dates. This is going to back up your date of diagnosis, your date of first contact, and your pre and post-treatment fields. If we don't have dates associated with, a biopsy and a surgery or the chemotherapy, then how do we know what order those happened in? So you want to make sure that you include the dates. So I want to just quickly go over some quality review examples. And again, just note that this is based on quality review visually edited data items in California. I do realize that this could be different from state to state, but I do believe that visual editing is pretty consistent in quality review amongst everyone, because we're all coding the same things and we want to make sure that those things are correct. And also my examples are based on 2019 cases. So these are a list of the visually edited data items for 2019 cases that the California Cancer Registry was reviewing, and they do a random review of the cases. So it went from everything of county of residence and race and ethnicity to pathology to grade to staging. So and treatment. So these data items kind of go the whole distance of the abstract of what they were looking at. So in 2019, they were looking at 20 data items. So as you can see here, like I said, it's county, race, ethnicity, data diagnosis, etc. They were also looking at treatment fields, surgery, and then all other treatment fields. But notice how surgery and all other treatment fields are just 2 items. They're not going to, what I call it, ding you for every single, if you got an incorrect date of surgery and an incorrect lymph node procedure, they're not going to ding you twice. They're just going to say, okay, that's 1 edit for surgery. And again, the list of treatment goes on and on and on and on. So just a couple of just 2 examples on visual editing. So first one is a prostate case. So the discrepancy that we received back from visual editing was on the EOD primary tumor. The abstractor originally coded the EOD primary tumor to 120, but the state registry changed it to a 300. So let's look at why. So their comment from the visual editors was that it's unknown if it's clinically apparent or inapparent on the prostate. Remember, I mentioned that earlier. That's why the DRE is so important. So the text in the abstract said, is a 63-year-old male with biopsy-proven prostate cancer here for treatment. PE within normal limits, no LAD, no mention of DRE. So they coded it to 120. Tumor was identified by a biopsy. Clinically inapparent or not palpable. Okay, that kind of makes sense because they came with a biopsy that was positive, But if you use 120, you know if it's clinically inapparent and not palpable. But we don't know, do we? Because that text says no mention of DRE. It doesn't say the DRE is within normal limits or negative. It says we have no idea if there's a DRE anywhere. Because more than likely, this patient presented already with a positive diagnosis and are coming here for surgery. So they said, sorry, you have to code that to 300. Localized NOS. We don't know if it's clinically apparent or inapparent. Okay, so the text does not justify the 120. So the 300 is the more appropriate code. So that's what I mean. If you can't prove it by your text, you can't use that code. The second one is looking at a breast case and at the EOD regional nodes. So originally the abstractor put 800 as the code and the visual editors changed it to a 150. So let's look at what the text was. The text in the abstract said that it's 41-year-old female with biopsy proven left breast cancer with bony mets. It was an incidental finding following a fall, which is kind of an unusual presentation, here for treatment. Left breast, 5 to 6 centimeter mass, positive palpable axillary lymph nodes, right breast within normal limits, and decreased range of motion in the right hip. So code 800 is regional lymph nodes NOS, but code 150 is clinical assessment only clinically positive movable axillary lymph nodes ipsilateral. Is 800 wrong? No. Is 150 better? Yes. Because it says in their own text, in the physical exam, that there were positive, palpable lymph nodes. The physician could feel them, right? So 150 is more appropriate because they were clinically positive or movable, and they were only in the right breast, or I'm sorry, the left breast. The right breast was completely negative. So this text justifies a more specific code, and therefore it should be used. You always want to use the most specific. Like I said, is 800 wrong? No, but 150 codes or paints a much better picture and is much more clear on how this patient presented. So I know this is only 2 examples, but it shows how much a code can really change based on your text documentation. So in summary, text is a crucial component of an abstract. It's the proof for all of your codes. I think I've hammered that in so far. You want to make sure that the text is short and concise. Only include what's pertinent. Start with your site-specific data items if there's any confusion over what is pertinent. And you always want to review the list of visually edited data items to know what's expected of you, to know what people are looking for. And of course, questions are guaranteed in life, but answers are not. And that concludes my presentation, and I look forward to taking any questions when they arise.
Hi, everyone, and welcome back to the Q&A session. Unfortunately, we are out of time for questions. Kelly has been answering questions in the portal as they have been coming in. So Kelly, do you have any closing remarks?
I just want to say thank you to NCRA for having me. This has been a great format. I am going to stay in the portal and make sure I answer all the questions. The only thing I would definitely want to address is I've gotten lots of questions about dates. Yes, you want to include all the dates. I just didn't in the presentation to be short and concise, but yes, definitely. But I will answer all the questions, and thank you so much for listening to my talk.
Thanks, Kelly. That is a great presentation, and it's always a hot topic, so we do appreciate that. For your next session, please go back to the agenda and select the track that you want to attend and find the next session in that track. Thanks, everyone.